Of course, thank you very much, Paul. Um, Good morning, good afternoon, dear team. Welcome to today's DCB Academy session on Volatile Coronaries. Coronary response from testing to therapeutic approach. This session will be presented by Dr. Jassim from France. Who is Dr. Jassim?
Yes, Jassim, Ahmed is asking to increase the loudness of your voice, if you can, please.
Is it better now?
For me, it's great. I don't know, Ahmed, can you hear us?
Yeah, for me too.
Okay, great. We can go on. Thanks.
Okay, thank you for the opportunity to present this interesting topic. So I made the topic in a scope of a case. So just be going through the pathophysiology a little bit and then going directly to a case that we did here in our hospital. And then we'll just shed light on the therapies that we can offer for those patients with the coronary spasm. So to start off, we know that the coronary angiography is a great tool. In the last 50, 75 years, we have advanced vigorously, yet it remains luminography, as we say, or a contrast silhouette of tool that we can see if there is a stenosis or structural characteristics of the coronary arteries. It misses the visual wall, it misses the vascular function. The coronary vaso reaction function plays a crucial role in the coronary blood flow. It's well studied since 50, 70 years, whether it is at the level of the epicardial coronaries or down the stream in the microcirculation. The mechanism to regulate this is various. Usually it's endothelial-derived vasoactive agents. And I always use this analogy that we can imagine the endothelium as a sandwich where it's between the circulating blood and the smooth muscle, and there is a stress from the right side and the left side. So the endothelium itself, it is exposed to various of factors. We can imagine the endothelium as a monolayer of non-atherogenic, that's not atherogenic. It's highly selective surface for diffusion. But again, as I said, it is exposed to shear stress. Whether it's high or low, at the long term, it will change this environment. As part of the shear stress response, usually there is the normal response where the nitric oxide will be released, and we will have some sort of vasodilatation. There are other substances where it's locally acting, short duration, and regulate this mechanism. We're talking about here acetylcholine, bradykinin, histamine, and else. So part of this cascade of action, there's also endothelial dysfunction, where the loss of ability of the endothelium to vasodilate properly. So we have the normal undamaged endothelium. The normal endothelium, we expect that there is an acetylcholine that binds to our receptors. This will activate a cascade of events, will increase the calcium accumulation in the visual wall. Later on, nitric oxide will accumulate, leading to vasodilatation. But in a damaged, an endothelial dysfunction situation, what will happen, this is due to various causes, whether hypertension, diabetes, smoking, or other substances, like even cannabis and cocaine. What will happen is that the enzyme that's responsible to release the nitric oxide in the vessel will be suppressed or deactivated, leading to accumulation of calcium, high calcium in the vessel wall, and finally vasoconstriction. So it was first described by Prince Bentel in 1959. So he experimented that. People come in, they have transient chest pain that responds to nitroglycerin. So he thought that it could be due to some sort of mechanism related to transient reversible causes. In the diagram here in A, he recorded the pain episode in relation to the ECG changes. We can see that there is a modification in the ECG, and then he gave a nitroglycerin where it relieved or terminated the attack. He also did a logbook for the chest pain, and he introduced vasodilatory medications where we can see on the right side less arrhythmia, less less attacks in this patient. So he was the first who reported, and then we have the team of Lodimir who first tested it in a coronary artery disease and coronary angiography setting. We can see there is a lesion here. They did acetylcholine, occlusive, nitroglycerin, and better. So it was well known, let's say 50, 70 years back.
So this is, Jasim, I have a question for you. It seems a different setting. So in this case that you just presented, there is an atherosclerotic plaque for sure.
Yes.
Of course, is very reactive to acetylcholine. And this led to the occlusion of the vessel. On the other hand, when Prince Metal described the vasospastic or Prince Metal angina, that was related to a normal coronary artery.
It is. So, there are types of coronary spasm. Some of the coronary spasm will have some sort of coronary. Here, it's a significant stenosis, but they are the first team who tested it in the cath lab. I know it's a different setting. It's not the coronary spasm where there is no coronary artery disease.
I agree. That's a nice case, technique. But I mean, when you have an atherosclerotic plaque, probably you have other, other enzymes, other triggers for the spasm as compared to a normal coronary artery.
Exactly. And nowadays we don't do that with such tight lesion.
Yeah.
Those are just like a slide on endothelium-dependent vascular function, endothelium-independent vascular function, where if there is a pathological dysfunction of the endothelium, acetylcholine, and instead of vasodilating, it will vasoconstrict. While for example, the nitroglycerin, regardless of the endothelial function, it will vasodilate. So for the indication of the exam, there is, let me move this. There is this group, the Coronary Vasomotion Disorder International Study Group. They published a good paper in 2024 where we can use the, how to say that, the exam. When is the best time to use this exam? Mostly, usually, and for our practice is when a patient comes with a typical chest pain, whether there is a typical spasm characteristics or not, we do an angiography. We don't find an obstructive lesion. Then we think about if there's the risk factor. We think about doing this exam. There are other settings where we can use this exam. I'll just let you go through later on with the paper. It's interesting to go through it. But in our hospital, what we do usually is that's our protocol. If you go back to the different studies, trials, you will see different protocols, different doses of acetylcholine or other medication that's used to provoke this exam. For us in France, the acetylcholine is not available. So we had to go with the Metargin, which is a methyl ergometrine. It's a medication that's used in the obstetric setting to control bleeding by vasoconstriction. So since the medication is available, it's easy access for us, we use that. So we take 2 ampoules of the medication, Metargin. We put 1 ampoule, which is 2 ml approximately, or 1 ml, sorry, in 8 cc of sodium chloride. We prepare as well verapamil IV. We prepare nitrate IV. Those are the doses. We have to have easy access to a temporary pacemaker. We don't leave it on the shelf. We just keep it next to the table. Most of the cath labs now they have 12 lead ECG, so you have to have an access to 12 lead ECG. In our hospital, the protocol, we stop the calcium channel blocker 48 hours before the exam, nitrates 24 hours. We inform the patient about the risk because the risk is a little bit higher as compared to normal angiography. But still, it's in a controlled setting, in a controlled environment. We prepare the femoral access, so it will be a femoral. In the cath lab, we go with femoral, as I said. We avoid radial here. It's possible. It is reported. Some studies, they do it through radial, but the risk is that you do radial spasm. And if you have radial spasm, it's difficult to take out the sheath. So for us, we keep it simple. It's echo guided. We do femoral. We have a closure devices. We can close it or we can like compress. So nowadays, with the echo availability, we go femoral for this exam. Second, you have to everyone has it in their lab, three-way valve for the access of the medication to give medications. As I said, the pacemaker is accessible and ready to be used. And then it depends what protocol you follow. In our hospital, we follow the intracoronary protocol, so it will be the half of those doses. This is the total of 0.4 milligram for 100 microgram in total. We inject, we wait 3 to 5 minutes, we take a film, and we take 12 lead ECG. We inject another. It's a pretty long exam, so that's why a lot of people doesn't like to do it. If you're going intravenous, then you just respect those doses. The risk of intravenous that you will cause vasoconstriction and other parts of the body, like radial or elsewhere. In the cath lab, as I said, we have to do a final coronary shot where there is no spasm, and we give nitrates even if there is not spasm. Verapamil is an option if you have persistent spasm. Temporary pacemaker if there's an occlusive right coronary artery spasm that's leading to atrioventricular block. And then at the end of the exam, we put a nitrate patch for 24 hours, as there are some case reports where there is a late spasm phenomena. So to avoid that, we put it for 24 hours, regardless of the result of the exam, negative or positive. This is as I said, the coronary vasomotor disorder international group. It's a busy slide. They have a criteria, whether it's a clinical. The point number 1 and number 2 is a clinical. Point number 3 is the angiographic, let's say, cutoff for diagnosis. For us, what we follow in our hospital is 70%, let's say, stenosis of the artery as compared to the reference artery. And chest pain or ECG only one criteria of the 3. We treat it, but probably we won't take him back to check it to check the vasoreactivity under treatment. Now I'll go through presenting a Madame X, 56 years old, no risk factors. She came to the hospital with chest pain, a little bit transient elevation of troponin. It's high sensitivity troponin. It was 60 only, and the cutoff in our hospital is 25. She has a smoker, 10 packets per day. She doesn't have family history of sudden cardiac arrest or past history of hereditary coronary artery disease. This is the coronaries. Pretty normal coronaries. We didn't have any issues. We didn't suspect anything. We stopped with the normal coronary angiogram. There were no lesion, neither on the right or the left side of the heart. And so we proceeded to MRI. This is the protocol in our hospital. We take the patient to the cath lab. We do the angiography. If it's normal, we have pretty good access to MRI. It's not every day, but we can do MRIs. So what we found is that there is a late gadolinium enhancement in the inferior-medial left ventricle. It was intramyocardial, and ejection fraction was let's say 52, limit normal. So after discussion, we said, okay, we discussed it with the radiologists in our hospital. The radiologists who reported that, he said, we cannot rule out myocarditis. There was no clinical indication of myocarditis, we said, okay, we will follow it up with an MRI in 5 months. She continued to have chest pain for the 5 months, usually relieved with nitrates. We did the MRIs. We saw her in consultation. The ejection fraction was 48 estimated by the how do you say that, by the radiologist, but she normalized the late gadolinium enhancement. So we said, okay, it's the time to do the provocative test. This is the left circumflex artery. Here we didn't take the baseline LAD shot, so we injected after the left circumflex artery, and directly we did after 13 seconds of the injection, we did the first left anterior descending artery shot. So you can see here, sorry, you can see part of it a little bit spasmodic, but it's not 70%. So we did the LAO cranial shot. Again, we have some suspicion at the beginning the first shot, I thought, oh, is it a bridge or not? But then we said, it's pretty normal. It doesn't fit the criteria. Within the exam, she didn't have chest pain here, neither ECG modification. We went to the right side, we shot the right. Again, it's normal. 3 minutes and kind of reactive, but no chest pain, no ECG modification, and no, how do you say that? No 70% stenosis. Again, this is the baseline at the left side of the screen. On the right side of the screen, we have the 5 minutes after the exam, after the injection. Again, we see some reaction, but for me, it's the same. So we said, okay, we'll go back to the LAD. We went back to LAD to check the LAD here to see if there's a spasm or not. So we checked it. We can see it's more reactive right now. For us, it was 70% stenosis. 5 minutes later, we waited. We can see it's more.
What about symptoms at that stage?
Chest pain without ECG modification.
So she had chest pain, just very late. Very late.
Kind of late and similar to the attacks she had. Then we went back to give the nitroglycerin. So you have to go back to the artery that we injected to make sure everything is good. And we give the nitroglycerin. This is the final shot before just moving the catheter. So after giving the nitrates, you can see that the artery took the caliber. So here it's a diffuse spasm, diffuse reaction of the RCA on the right side. And this is the left coronary artery after coming back to it. And we can see the spasm persisted in between injecting the RCA and the LAD. And this is the shot after the nitroglycerin. So it took the caliber. For us, it was a positive test. Chest pain. ECG modification wasn't clear, but chest pain with spasm after ergometry. So what we did is that we increased her non-dihydropyridine calcium channel blocker, verapamil, and we added amlodipine, and we continue with aspirin, statin, and nitrate sublingual. We didn't think that we will add a nitrate patch here. We don't pump them with the medications and afraid of side effects. We say, okay, let's see how it goes with that, and we will retake her for the exam while not stopping the medication. So we will not stop the medication for the next exam. We'll just continue the medication and we'll do the exam and see how it goes.
Why do you want to redo the examination? I mean,
so
if you have a therapeutic success with this improvement, an increase in verapamil, and also adding amlodipine, so why do you want to bring her for an invasive angiogram? You know, that's, I think, more for your eyes instead of for a clinical advantage of the patient. Because, again, this is not a clear, vasospasm leading to the occlusion of the vessel, but I agree with you that there is an effect over there, and probably this effect will go out with the medical treatment, and also because we don't have anything else we can do.
Exactly, so I agree with you 100%.
Which is the meaning of doing another angiography, which is invasive?
Our protocol tend to avoid that. So if we arrive with the diagnosis, we add the medication. We see her in the clinic. If there is no symptoms, we're happy. Sometimes we take them back to see the reaction with the medication. If the angiographic, I agree with you, it's controversial here. Not many of the studies do it. Actually, I'm not sure if some centers are doing it. We took her back because she was symptomatic. So
she was symptomatic or asymptomatic?
Symptomatic. She has symptoms. No
symptoms.
Okay, so
that's agreed. It's an indication for bringing her back, because despite optimization of therapy, she's still symptomatic. So yeah, you need to understand it better.
So again, she had symptoms after four months follow-up. It's less, but yet it persisted. So we thought, okay, we'll take care, but we will not stop the medication. We'll see how it goes.
Okay.
So I will not go through the whole exam because it will take time. I just make here the baseline, the most prominent, let's say, spasm, and here after nitroglycerin. Again, it is reactive.
Yeah.
Despite leaving the medication in place, here again we can see that there is some sort of spasm. Not as much as the last time, but and this is after nitroglycerin. So what did we do here? We she had headache during the, if I remember well, during the nitrate patch that we gave her. So yeah, we increased the a little bit the verapamil since she can tolerate it very well, and she's planned for a follow-up. No more angiography here, so we can only provide her with medications. Some might argue that we should do a microcirculation study. We didn't do it since for us it won't change much of the let's say the how do you say the treatment plan.
Yeah. No, let me comment on the therapy.
So
calcium channel blockers, of course, should be the first choice.
Yes.
You can add, a dihydropyridine to diltiazem or verapamil, whatever.
Yes.
And nitroglycerin, yes. I'm not sure about aspirin and statins. That's, endothelial dysfunction. Probably this endothelial dysfunction is different from the endothelial dysfunction that is leading to atherosclerosis. So unless you are giving statins for primary prevention because she has an LDL of 180, I'm not sure. I'm not aware actually of studies having shown an advantage in these patients. And the same thing for aspirin, nitroxide, platelet aggregation. This is very theoretical, very bench test. But in real life, you always have to wait the risk of bleeding, giving aspirin for 30 years in a young female patient to a real evident advantage.
I agree with you. I cannot agree more. So aspirin and statin is a controversial medication that we will. This is a protocol that we follow in our hospital. It is based on small studies, maybe. What I found online is that there are some small studies where they follow the patient with spasm, with a positive test, and in the long term they will develop some sort of atherosclerosis. And again, it is theoretical. Here we're talking about pathophysiology, and at the level of the molecules, we know that the nitric oxide is not working very well. Okay, maybe it has some sort of, there are some sort of small studies, but again here I agree with you. The indication is not class 1. But the nitroglycerin calcium channel blocker, this is the cornerstone of the therapy, and those what will help most of the patients. Some argue for angiotensin II as well. If there is an indication like blood pressure, you will favor this, or sometimes like if you have a renal, if you have other indication for angiotensin II, so you ACE inhibitor, so you'll favor this instead of other hypertension medication. But I totally agree with you. The aspirin and statin, I have to dig deep into why it's added. What I found is small studies where they positive patient had atherosclerosis in the future.
And Eman is asking for nicorandil. Do you have experience with nicorandil?
Yes, nicorandil, we added, like for this case, I think it's a good indication. We didn't add it. I don't know why. I don't know why. But if you go with the, there is a graph at the end of the of this slide where they discuss it, and they put it in the step 2 for the treatment. Is that vasodilation medication? It will give the vasodilation. We tend to use it a lot here in France because it's available. We use it for angina in general, whether it's spastic or not, for medical treatment, let's say. Here, I don't know why we didn't use it, actually. It's a good point, and it's a good indication as well.
And any role for Ranexa, to your knowledge?
For my knowledge, no, I don't know. I've tried to read it. I thought the presentation is tomorrow, so I didn't prepare. Sorry for that, but we don't use it in our hospital. I've read some experimental drug like antagonist for the endothelin 1, but it's experimental. We're waiting for the results of the studies and all. So for now, what it's not a class A, but what the cornerstone is nitroglycerin, calcium channel blocker, and most importantly, to stop smoking. Smoking is the cornerstone here. It is the provocative medication in real life, and people feel much better after stopping smoking. I'm not sure about passive smoking. Tried to look it up. I couldn't find something good. But smoking is so what we do is we have a smoking clinic. It's not a clinic, it's a nurse. She has a diploma in that. We try to and usually the general doctor will also speak to him about smoking, and we have good access here for anti-smoking medications. Beta blockers, the general rule is avoid. If there is an indication, you have to we tend to use nebivolol. It has some vasodilatory effect as well, not like other beta blockers. If you will try to use cardioselective beta blockers, but in general rule, try to avoid that. We try our best to avoid beta blockers. I'm talking about beta blockers here. If there's another indication for beta blockers like arrhythmia or whatever. Serotonin, we try to avoid it. Again, it's the pathophysiology here. I don't know if there is any data around that, but we know that there will be that serotonin will cause vasoconstriction. So we tend to avoid this SSRIs, and we ask the psychiatrist to put another medication.
For depression.
And the last thing is if there is an hospital cardiac arrest, we did the test afterwards. So we got the patient back. He went, let's say he went well and he's doing well. He went home with medication, and when he came back, let's say for afterwards to do the exam, and it was positive, we kind of discuss doing an ICD as well. And I asked my consultants, I think they did it once or twice, an ICD for out of hospital cardiac arrest after a strong positive test. Here we don't wait like it's doubt, we're not sure the criteria, whether it's angiographic criteria, clinical criteria. It has to be, because before putting the ICD, we have to make sure that it is a real spasm that caused that arrhythmias. This is a good paper. It's a summary of what we spoke about, and we can see here, I think, nicorandil as a second line. And it's a paper. I think it's about like myocardial infarction in the setting of normal coronary artery disease. We can see it's variable, the incidence of spasm, 15 to 71%. The risk factors, again, smoking, age and origin. I didn't understand why I raised CRP. Yeah, so that's just a reference for the attendees if they want to go back to a lifestyle exercise. There are some data that exercise improves endothelial dependent vasodilation. Small studies that we can't count tone, but like interesting to know that flavonoid-rich dark chocolate, specifically 40 gram of dark chocolate, 70% coca. This study was on a patient with a heart transplant. It was had some vasodilatory effect, and caffeine, always people ask whether it will increase the sympathetic tone, whether it will play a role. There's no data on that, but if you're going for an espresso, couple that with a flavonoid-rich chocolate.
You cannot ask an Italian guy to avoid the espresso.
I agree with you. Thank you.
You did a great job, Jazim. I really enjoyed this presentation and I learned a lot. Are there questions from the audience?
Jason, I have a question.
Please, Emma.
Since you have reviewed this subject, so the talk is about endothelial dysfunction, but how about the like neuroendocrine axis causing like the stress effects on the severity of vasospasm? Like, is there a possibility? Because I've seen it here, especially in where I am right now. I've seen it a lot in younger patients who have zero risk factors, they present with severe spasm, and I feel like the stressful lifestyle and the way they are, or type A personality, let's say, is like makes them prone to that. So any studies about that? Any words about like psychotherapy being a part of managing this kind of like anginas?
Good question, Iman. Yeah, so going through the literature while preparing for this presentation, I came across the Takotsubo syndrome, and a lot of papers are talking about whether it's the spasm that can explain the modification that we see on the LV or not. Some argue yes, it's the same idea behind the caffeine. If you have high intake, it will raise the sympathetic tone, and then it will have some sort of effect on the coronaries. I don't have the answer to this question. I have to go back to the literature specifically in terms of the neuro cardiology axis, whether if you are more calm, whether it's if you do meditation, would that change or not? Not sure. I don't know about the data. I don't know about the what does it say. Other risk factor with young people, since we mentioned young people, now they have more access to marijuana, cannabis, and all. We tend to see a lot of people who are taking those recreational drug, if we can name it like that, who tend to have the zero risk factor. They don't smoke. They just take that once in a while, and they come with a spasm. And once they stop those medication, they feel better. And so this is another risk factor that we see more and more.
Yeah.
Just a more technical question.
Sure.
When you do the testing, do you test both the left coronary and the right coronary? So is it usual to get spasm in one territory but not in the other, or is it a global thing usually? So
Good
if you're
question.
going to get it in one, then you will have it in the other. Thank you.
A good question. So practically talking, if we have it in one territory, we don't check the other territory because we don't want to take the risk. Let's say we check the right. We usually start with the right. And if it's spasmic, if there is a spasm in the right, so we don't check the left because there will be a risk of doing the test while it is positive. We consider it as positive because it will not change. And
treatment is the
friends,
same. It's medical treatment. Yeah, absolutely.
it will be the medical treatment at the end. We won't be putting a stent there, so we don't do it, the test. Is it the interesting part of it is does that affect a territory? This is a research question, actually. I asked my at the beginning of my fellowship, I asked my mentor. So he doesn't do it because of the risk. So and it won't change the medication or the management plan. But if I'm not mistaken, I hope I'm not hallucinating. Back then, when they first were doing it, they do it in CCU, and they pass the medication IV in the CCU, and they go clinical, either chest pain or ECG modification. They don't do angiogram, so they do it bedside in the CCU. My mentor did it a couple of times, a lot, he told me. So what's interesting, I think, if I'm not saying, I have to double check this information, there will be changes in the ECG modification in different territories. So maybe that reflects that it's not a global problem, it's a kind of a territorial problem. Why? I don't know. Another question that I asked him, whether there is any genetic predisposition, let's say if there is any genetic factor here, I couldn't find the answer. Yeah, and yeah, that's the answer. I hope that answered the question.
Yeah, great. So guys, I need to go because I have a couple of commitments here. But again, I enjoyed this lesson a lot. I have a, is Ahmed still here and Ayman? Yes. So you recently joined the DCB Academy. We gave you a few commitments. So please let channels stay open. If you have any any suggestion for topics that you would like to see during a lesson, or for topics you would like to be involved for research or new research areas, please write me and let me know, or write in the chat as you prefer. And we would like, to get you involved according to your time and to your willingness to be involved. Okay, so I want to make this clear.
Yes, thank you very much, Bob. Thank you, Justin. It was a very well-structured lesson, like from definition all the way to the prevention. I learned a lot. Thank you.
Yeah. Thank you, guys. Speak soon.
Thank you.
Okay,
Thank you. Thank you, Justin.
Bye-bye.
Bye. Bye.